Um, I'll start. Well, because I don't know much about anything else than CTO PCI, unfortunately. Uh, I really took the perspective of talking to you about CTO PCI, and I think it's okay given the current case and what we should be expecting into the next few years, or at least in my view. These are my disclosures. But having said that, this is Niels Bohr is a famous Danish physicist. He won the physics prize in 1922. He said prediction is very difficult, especially about the future. And and he also said something that's very important, and I think you probably all share the pain. An expert is a person who's made all the mistakes that can be made in a very narrow field. Uh, and I think I can define myself as an expert because I've made many mistakes. And from where I want to sort of bring you to the next steps of what we should be aiming for CTO PCI. Today, I will focus on three different issues, uh, three different issues, which are basically the risk component of the hybrid approach, incorporating the risk into the decision model, which has not been discussed enough, I would say. The new strategies to reduce risk and preserve long-term outcome, and new tools for calcified plaque. So here, we know that the fundamental of dissection reentry concept is that the dissection is not a complication, but a mode of treatment. We know there's many ways to cross a CTO. You can cross it intraplaque or extraplaque. You will, in the upcoming circulation paper on the CTO arc, we define the new maneuver as being intraplaque or extraplaque. And we know that subminimal stenting is safe, better than a closed artery, and has no impact on stent failure from the consistent CTO paper. The algorithm is really focusing on doing things efficiently and fast. We know knuckle wires are safer than straight wires because knuckle wires tend to stay within the vessel structure. And we've been over time stressing the importance of changing fast and going from one approach to the other approach. You've tried to integrate, you go retrograde if you think you've got an interventional collateral and everything. And I think what remains to be the most important thing to tackle in our world is the concept of interventional collateral. Because the cap, the proximal cap, we found many approaches to get around issues with the proximal cap, and to get around issues with the length of the lesion. We've found solution as well. But for interventional collateral, although we've became better at crossing those collateral, we still have issues, and these issues may kill the patient. As you know, when you're going retrograde, you have a fourfold increase into complications compared to an integrated only procedure. And in the open CTO trial, in the 9 patients who died, 5 of them had a perforation of an epicardial collateral, and most of them were post-CABG. So when you're committing yourself to go into an epicardial collateral, it's not because you've got the skills that necessarily it's the safest approach. And even if the algorithm would tell you, you go retrograde because this cap is ambiguous, that might not be the answer. So there are new strategies to reduce the risk and preserve long-term outcome. I want to discuss a bit about this. We're all aware about device-based versus wire-based reentry. AFR should probably be in that second part. However, I think they're all a variation on the same theme: STAR, mini STAR, contrast-guided STAR last, and then now AFR. Basically, a non-targeted reentry with either a straight or a knuckled wire. We've known for a long time that the outcomes with STAR, when you follow it with stenting, are pretty bad. Like if you finish with a TME2 flow, the reocclusion rate is 69%. So 29%, and the restenosis rate is 69. But even if you've got a TME3 flow, you can still have 50% restenosis. So we're clearly not there, especially when you look at consistent CTO and in a single digit TVR and complication. So Lorenzo and myself with actually some folks I see here on the camera, Manuel and Soledad, we gather multi-center experience on controlled reentry versus not controlled wire-based, and we clearly could show that the Stingray reentry yields better outcome. And this is in either you go retrograde or you go antegrade. If you do modern dissection reentry, you sort of get the same outcomes you would have with an intraplaque crossing. And obviously this is now confirmed with the large 1,000 patient consistent CTO study. I was talking to you about, yeah, but what do we do if we have an ambiguous proximal cap? Well, it's much less of an issue now. You can make your own cap wherever you are. You can do a scratch and go, you can do a base technique, but these techniques are very efficient to get into the vessel structure and then navigate into this vessel. And I can see the operators a few minutes ago struggling and getting to the proximal cap, but the proximal RCA is full of disease. So you can just blow your balloon proximal and then get your wire subintimal and get your case going. Here's a case of a difficult ADR, 70-year-old man, post-cabbage. He's got an RCA CTO, proximal ambiguous cap, several sociocollateral, EF is 15%. I could go retrograde, but if I go retrograde, I will probably need support and maybe an impella because it may become very unstable. So I'll show you the angio. This is a triple axis here. We've got a catheter in the lima, catheter in the left main. And you can see that the proximal RCA is extremely ambiguous. You can see like there's two channels going, one is going to a bridge collateral. And if you're trying to go even if with a soft wire into there and play in there, you can have a bad surprise and a complication. So in this case, and also going retrograde would not have been easy. Easy technically, but with this EF, we clearly wanted to go antegrade. We got a nice landing zone. So what we did the base technique. We just blew a balloon proximal, got a wire subintimal right there. And once we're in position next to the balloon, the knuckle flies down very easily, and you could travel up to 30 millimeters of coronary within seconds. At this point, my catheter is positioned in the perfect spot to deliver a Stingray. We have a trap liner to cut to cut forward flow that could cause hematoma, and then perform a stick with an Astato 20, which is now my favorite wire for doing the stick. And then we flipped to a Pilot 200 and got this case done in about 20 minutes. So it was a safe way. We solved the proximal issue. We performed a reentry that was targeted. And when it works, it works. But I'll be talking about sometimes when it doesn't work. Here's another example. Poor landing zone, and again, a situation of a distal cap at a bifurcation. Poor landing zone, like a bit of disease, but you gotta see a channel. And there's some epicardial risky collaterals and maybe some septals. You see that PL is quite tortuous. It's in the AV groove, and I'm not a big fan of crossing those ones. And the proximal cap is ambiguous. You know, the algorithm would tell me, why don't you go retrograde? Well, if I go, I'm gonna serve some septals, and I didn't connect. So what's next? Well, I'm gonna do a base knuckle. So here's an example. It's a balloon that's inflated. And then when I'm pushing the wire has no choice to get into the wall because my balloon is blocking the lumen. So now the knuckle is in the wall, the microcatheter is advanced, and then got the knuckle down and got a wire. And in this case, we could actually see that the reentry zone was not that bad. It was a bit long. We positioned the Stingray, got a stick. We tried with the Pilot 200, didn't work. And then we used the Hornet 14. The Hornet 14 has become my favorite wire because for the stick and drive technique, is very nice. You can see I pushed a bit my Hornet, I pushed a bit more, and actually I was wondering, I thought I was in the lumen, and actually I advanced the micro catheter and I could get into the PLVs very easily. So you can see that this wire, this case was managed with only antegrade techniques, and after T-stenting, we got a good result. So, but what if you fail ADR? And I'm sure you've all shared this experience of you're pulling out your Stingray, hematoma grows, and you don't have a safe retrograde approach. What can you do? Well, very good data coming from Aaron Grantham and Bill Lombardi, but actually it's Bill's center where everybody knows Bill's. He's been, he had this concept of if we can fenestrate the vessel, defer stenting, which is more than subminimal plaque modification. You really want to induce some of flow in that coronary when you fail. So fail elegantly and invest into a second procedure, you can have good success. So this is like 4%, like 5.8% STAR technique done in failures. So it gives you an idea of a success rate of Bill Lombardi, like 96%. But these failures are like almost all treated like this. Failed ADR, failed retrograde, side branch rescue, they're all the reasons why he brought the patient back. What happened is that post-STAR, it could still have about 78% latency without stenting. And now in 2.4 month delay, and the range is about 1.5 to 3 months. With the second procedure, it could increase the latency to 88%, which is remarkable. And I want you to show you a reason why I became an expert. And if you recall that quote from that Danish physician, it's because I've made many mistakes. So I'll show you many mistakes on this case that I would do differently now, but how we solved it and how we could be successful on the long term. So non-ambiguous proximal cap, good landing zone, and not much collateral on an LED. Proximal to the bifurcation have like a nice landing zone. So there you go. It should be an antegrade wiring case. And if I fail, plus or minus ADR. You see the Pilot 200 and the Gaia, they got me there. It's a beautiful spot to deliver a Stingray and do my retrograde, my attempt. But the problem that I didn't see is that all my collaterals are coming ipsilateral. So every time I'm testing, I'm filling the subintimal space with blood. And I should have not do this. I should have selectively engaged a collateral and do selective injection or ping pong catheter and bring a turnpike to block the entry. So that's the start of a failure. I'm trying to do stick, swap, and I will go quickly, but you can see now that the hematoma is growing. And I just can't any control on this vessel. I'm sticking, driving, I'm doing all the techniques. And unfortunately, I just cannot get anything going. So at this point, I move into an investment procedure. This is a start technique that I'm doing into first diagonal. So I popped into the diagonal, and as you can see, the pop and release and big knuckle to small knuckle is very an important feature you got to be looking angiographically. And then afterward, I got into the LED, and I stored the distal LED the same way. So you can see now, and if for the ones in Europe, we'll have the Gladius MG or the Gladius Mongo in the US. We're about to have it in Canada. It's a Gladius that has a grinding point that makes it fold to be a perfect knuckle wire. So, and I very encourage you to use that wire. It's a game changer. So post-angioplasty, this is what we got. And we use DEB in the proximal segment right there where was the CTO. You can see that the vessel is pretty much destroyed. Patient doesn't have any angina. And this is the pre-star, and this is the post-star investment. I finished up the case with this result. But this is 3 months later. There's the segment where there was a CTO has stayed open where I used drug-eluting balloon. And now the CTO is not a mid-LED CTO. It's now a very short distal LED CTO that I have here. And I would, so look at how it looked, and look at how 3 months later with the STAR technique, what happened into the healing of this vessel. So in this case, I was able to cross distally with wire, and then we performed stenting, and we got a very good long-term result. So it made me think of all the options we could do in CTO PCI. Is it better to go and do risky techniques and that could actually lead in deadly complications versus a two-step procedure where actually you could do techniques like this? So we published recently our experience. It's only 3 cases in the paper, but we've done 7 cases so far where we've used drug-eluting balloon in the segment where we failed. So there's no stent there. You're just starring the vessel, you get the drug-eluting balloon in your segment where there was the CTO, and none of the case when they came back, they had restenosis in the CTO segment. Give you another example of multiple failures on my side. You can see that juicy epicardial coming from the circumflex and a big epicardial coming from the LED. So I said it's a good antegrade case, bit of ambiguity, proximal, but again, proximal cap is no more an issue. I can do a base technique and get into it. So I blew a balloon proximal, induced a dissection plane, got into the dissection plane, and got a knuckle going all the way down to the reentry zone. And here's what I did wrong. I was greedy. I try to say, okay, I can be better than anybody. I will try wire and I'll try to re-enter just with wires. And guess what? That doesn't work, because when you do this, you don't take control on the vessel. And at this point, I started to lose flow because the collateral from the RV branch is so humongous that it's filling my hematoma. I want to skip this because all the rest is because of this super big hematoma, despite the trap liner and despite everything. I've ruined my case from the get-go by attempting with the wires. So I'm not able to get back, double stick and swap. I have a failure despite a good position on my Stingray there. And then I do a small integrate test. And actually now there's flow integrate to the RV branch. You can see the vessel, and I decided to star. So I start a vessel in the PL, and now I have like a very extensive dissection. I placed a wire, and then I said like, okay, I've gained the vessel control now, but what is it? Well, I have a big dissection. I will only treat my ego now just to have a success, and it shouldn't be this. I will stop there, and I will do my investment. So I brought the drug-eluting balloon, and then call it a day for this case. Patient came back 3 months later. No more collateral from the LED, and guess what? The vessel is completely changed. The CTO is no more proximal, but it's a weirdo CTO at the distal RCA that actually, as soon as I got there with the mic, so here's just a workhorse wire. And you can see now there's flow in the vessel. So this case was really easy. I thought I could, that's a new CTO of the distal vessel that's like basically dissection planes that healed like this. And in this case, I needed to use a Hornet 14 that I got into the PDA, and we got a good result. So in terms of questions that we don't know now is it okay to do the stenting if you did a star and you re-enter proximately and you haven't lost branches? I think so. You know, in my perspective is if you preserved all the branches, I think it's pretty okay to just go and stent. But if you've shoved a lot of branches, I would urge you to consider the investment technique or star and deferent. Should it be a bailout or using in higher risk procedure? This is what I want to bring you today. I've shy away from doing risky epicardial to just do this and actually doing more of these procedure. What is the real value of deferred stenting? Shorter stents, probably. But I think in these, when I look at these cases coming back, I don't think you stent shorter. Actually, I think your stent is long. And the timing of the repeat angiography, 1 month, 3 months, I don't think it's a big issue. And the value of DEB on such cases, although we showed very good result, would need to be confirmed with other cases. I want to just skip to my last topic with you, which is new tools for calcified plaques. I'm the lead investigator with the new technology that uses a shock wire. It's a wire that generates shock to the distal tip that produce like a jackhammer effect. So as you can see, it's called the sound bi-crossing system. And actually the mechanism of action is that it sends it moves a 1 micron distal range, the distal wire, and converts this impulse into a mechanical activity. It's very good on calcium and it's soft on healthy tissue, pretty much like IVL. So we're really into the same concept. And this is a TV show that was done in Canada where they showed the catheter. So it's a model where you can see the wire that's attached to the proximal generator. And this is plaster. This is real plaster, hard concrete plaster. And this is the wire on the concrete plaster, jackhammering through it within a few seconds. So clearly, and this is me with an egg. So what am I doing with an egg? I'm gonna show you that with this wire, look, I'm pushing the wire on the egg, it doesn't do anything. And now I'm gonna activate the wire and I can do a 0.0014, just little hole in the egg within seconds. So clearly the technology has the potential, we just have to find where would be the solution. Here's one of the cases we did, a left main CTO with, and this is the dual injection. We've got clarals, not the dual, but we've got clarals from an SVG to the PDA. This is the dual injection that shows you that's very angulated, seems to be a ramus distal to the circ distal cap, and it's very calcified. So in this case, we set up the case. I'm bringing the microcatheter to the proximal cap. Once we've placed a microcatheter, we will attach the wire to a console. And now we're ready to start doing the procedure. So this is the active wire and the energy that's applied. So we're at the proximal cap right there. And this is the fluorostor. So this is the active wire right there because the wire is called the active wire. And now we deliver the energy and you will see the wire sailing into the ramus. It's not a wire that has a good torque response. You can imagine it's attached to a console, but in terms of busting calcium, it will be probably very good. We're in the ramus, we turn this into stenting and we got a good result. So far we are awaiting FDA approval for our clinical phase 1 trial. Health Canada has approved a single arm study that we're doing. So that's one of the reasons I've done more cases because we could have Health Canada. We've done 27 cases with a very high success rate. I cannot disclose the numbers for now. We have good efficiency, which is defined as 3 millimeter progress of the wire in 70% of the cases in all calcified. And the good thing is that we had no wire exit. So this wire, because it's sort of a nitinol style wire that jackhammers, we haven't had any wire exit of the wire. The wire, the only thing it does, if it doesn't cross into the true lumen, it gets some intimal. So it's a very good news. And we're sort of asking ourselves if it could be a better or a safer approach as a cap buster than hard penetrating wires such as the Hornet 14 or Confianza Pro 12, where actually you can definitely exit the vessel structure. So in conclusion, the risk needs to be acknowledged and be put into hierarchy with regards to efficiency with the hybrid approach. I don't think we can only say interventional collateral, go retrograde, because if you're committing to an epicardial or even in septals and you've missed all and you don't learn how to manage your antegrade case, you will increase your risk of complication. I think in the hierarchy, we should always talk about safer septal versus antegrade wiring and ADR versus a riskier epicardial crossing, and especially in post-CABG, because these are the ones who can go really sour. I showed you very promising results with the STAR endeavoring stenting or subminimal plaque modification or investment procedure. And I want to raise the your awareness, or open your mind about the possibility that our procedure could become a two-step procedure in some cases. And now I always consent all my patients to a two-step procedure. So I tell them, I may succeed today, but if I don't succeed, I will bring you from 1 to 6 months to 3 months, and we will complete the case. And if you don't agree to that part, I'm not going to do your case. I'm not going to do it, because I have other cases to do than someone who doesn't want to come back. And no one has ever said no to this approach. And I showed you, and again, I'm an investigator on this, but maybe this new jackhammer-like wire technology, that's very novel. It's there's been a lot of energy-based techniques that's been used in CTOs, but now it's something that is looking for FDA approval that could become a good asset in our armamentarium for CTO PCI. So, and again, I would like to thank Ignacio for this very kind invitation. I want to congratulate Ignacio for that very, very well organized meeting that I really enjoyed last year with you guys in presence. But I guess I have to enjoy the cold here in Canada now, and maybe just wish you good luck for the rest of the meeting. Thank you very much. Any questions? Any questions?
Stéphane, do you copy?
I do.
Can you hear me?
I do.
Signal with the catalog. Oh, no.
Yes. Just one quick question, Stéphane. Yes. I know you are a little bit on a hurry because you have to record something for TCT like in 3 or 4 minutes.
Yeah, that's okay. We're fine. Go ahead.
Yeah. You did not mention much about orbitational atherectomy, about laser over standard wires. Are you implementing these techniques in your practice?
Yeah, I think all these niche techniques have a role, but they're gonna be I think laser is for the uncrossable lesion that is not super calcified. So you don't have that many cases like this, but it's a good, I put it into the nice to have but not must-have tool. Regarding IVL, for sure, it will be a game changer. I think it will take most of the plaque modification market, especially when we're dealing with large vessel and deep calcium. I think ROTA will always stay because for ROTA, it's for superficial calcium and eccentric calcium. Sometimes it's the only thing that works. And finally, you discussed about wiring. I think the wires, all the wire technology that's coming on the market are pretty much Me Too's. I haven't seen it in the last 6 or 7 years. Wires have been really game changer. Maybe, but you know, you've got the same flavor of the Gaia. You've got the same flavor of the polymer jacketed. You've got the same flavor of the. So in the end, it's I think people have to be to use the wires that they're confident with and understand what the wires are aimed to be doing.
Okay, thank you very much, Stéphane. It is wonderful to have your view. I think you are a visionary in the field. We learned a lot with you when you were here and also in my time in Canada. And I hope to see you soon personally.
Yeah, me too. Like I look forward to travel a bit further than Montreal. Take care. Okay.
Thank
Good
you very
luck.
much.
Bye-bye.
Bye.